Okay. Okay, guys, welcome back. There is some technical issue. That's why, unfortunately, we have to cancel the last session. So anyway, let me begin from the beginning. So what we have started, we have started with the infective endocarditis. Now, what exactly is infective endocarditis? We have discussed, sir. So infective endocarditis means because of some infective agent, there is endocarditis. Okay, inflammation of the endocardium. Even in rheumatic fever, we have discussed that there is endocarditis. Okay, mitral valve regurgitation, mitral valve stenosis is seen even in rheumatic heart disease, but that's not infective endocarditis. There is no infection over there. Okay, it's an autoimmune thing in rheumatic heart disease. Now, because of some infective agent, now there is endocarditis. So that's what is infective endocarditis. So now let's begin. So it's the endocardial inflammation caused by infectious agent. Okay. Now, what is the most common infectious agent? It's different in different conditions. In native valves, okay, imagine I'm the person who is having normal valves, not the prosthetic valves, normal valves, heart valves. So, what is the most common cause of infective endocarditis? See, in a community, in a general normal community in the society, the most common cause of infective endocarditis overall most common is streptococci. Okay, overall it is a streptococcus, sir. But if they ask you specifically in infant population, infants, the most common cause of infective endocarditis is Staph aureus. Okay, so coagulase positive organism Staph aureus. And in a hospital setting, okay, if you are in a hospital environment, then the most common cause of infective endocarditis, see, nosocomial means a hospital environment. The answer is going to be Staph aureus. So hospital environment Staph aureus, infants Staph aureus, but overall most common cause of infective endocarditis in a native valve person is going to be streptococci. Now in prosthetic valves, what exactly are the prosthetic valves? Imagine that the patient is having some problem, mitral stenosis. Okay, the patient is having mitral stenosis or aortic stenosis. Now this patient have gone through the valve replacement surgery. Now he is having the prosthetic valves. Even the prosthetic valves are made up of the biological material. Okay, the biological material. Now even these prosthetic valves can be affected with the microorganisms. Okay, so prosthetic valves can be affected. So there will be endocarditis, prosthetic valve endocarditis. Now if there is endocarditis within 1 year of replacement, within the first 1 year, okay, so then it is called as early onset endocarditis. Early onset endocarditis in the prosthetic valve, the most common organism is going to be Staph aureus. After 1 year, sorry, not Staph aureus, Staph epidermidis. Okay, Staph epidermidis in the first 1 year. That is the early onset prosthetic valve endocarditis. Staph epidermidis, the organism which is going to live on our skin, the coagulase, a negative organism. After 1 year, okay, after 1 year, the answer is going to be Streptococcus viridans. Okay, Streptococcus viridans. Now, in IV drug abusers, imagine I am the person who is doing drug abuse. Okay, what I have to do? I have to take the injection. What I will do is I will take the injection and I am going to take this drugs into my veins. Okay, I am going to take the drugs into my veins. All this, all these drugs, whenever I am taking, what happens? The bacteria which is present on my skin, okay, the bacteria which is present on my skin can get access into my bloodstream. So all this venous blood, where it will come? It will come into my right side of the heart, right atrium. If all this bacteria is coming into the right atrium, which valves are going to be most commonly affected? The valve which is present between the right atrium and the right ventricle, that is the tricuspid valve. So tricuspid valve is going to be most commonly affected. So in IV drug abusers, remember, in IV drug abusers, the most common valve that's going to be affected is the tricuspid valve, and the most common organism that is responsible for this right-sided valve endocarditis is again Staph aureus. Very important MCQ. Very important MCQ. Now after this, what else you should know? So even the drug abusers, okay, the left-sided valves can be affected. Okay, then what is the most common causative agent which is causing this left-sided valve endocarditis? Again, the answer is going to be Staph aureus. It doesn't matter whether it is right-sided or left-sided, it is a Staph aureus. Okay, in IV drug abusers, remember the most common valve that's going to be affected is the right-sided valve, tricuspid valve, Staph aureus. In left-sided valve endocarditis also, the most common causative organism is going to be Staph aureus. If you don't find the Staph aureus, then answer the Enterococcus. Okay, if you don't find this option Staph aureus, then you can mark the Enterococcus. So that's it. So here in this slide we have seen what are the infectious agents, what are the causative agents which are going to cause infective endocarditis, right? Now let's try to understand. Okay, in reality, imagine, sir, if Staph aureus get access into my blood, if Staph aureus because of some reason it got access into my blood, do you think that Staph aureus is going to cause endocarditis in me? Staph aureus, it entered into my bloodstream, sir. So this blood is going to the heart. This blood is going through the valves. Do you think that I'm going to develop the infective endocarditis? Usually no. See, to develop this infective endocarditis, see, there should be a pre-existing lesion in the heart. There should be a damaged valves or pre-existing some heart condition should be there. For example, like mitral regurgitation where the valves are inflamed, valvulitis should be there. So, in these persons, whoever are having the pre-existing valvular lesions, they are more susceptible to develop this infective endocarditis. Okay, so now the point which I want you to know is, so patients with the pre-existing heart diseases is at a risk of developing infective endocarditis. What is the most common valve that is going to be affected? Mitral valve. Mitral valve, again same in the rheumatic heart disease also, in rheumatic heart disease also, the most common valve that is affected is the mitral valve. In all the heart conditions, the most common valve that will be affected is the mitral valve, sir. Okay, just keep that thing in your mind, blindly keep that point in your mind. Okay, the mitral valve is going to be most commonly affected in majority of the conditions. Okay, now which valvular lesion is highly likely to develop infective endocarditis? Is mitral valve is going to be affected, but there can be mitral valve prolapse, mitral regurgitation, mitral stenosis. Which valvular lesion is at a high risk of developing infective endocarditis? It is mitral regurgitation, sir. Okay, so which valvular abnormality is highly associated with development of infective endocarditis? It's a mitral regurgitation. Mitral regurgitation, especially if you are preparing for the board exams like usmle, then the answer is going to be mitral valve prolapse. Mitral valve prolapse, because the mitral regurgitation is usually associated with, mitral regurgitation is something associated with acute rheumatic heart disease. In the developed countries, the acute rheumatic heart disease cases are very less. So in those developed countries, the mitral valve prolapse is highly associated, okay, highly associated with the development of infective endocarditis. But usually in Indian exams, mitral regurgitation is the answer. Having said that, now what is the criteria? Okay, what is the criteria for the diagnosis of this infective endocarditis? For acute rheumatic fever, the criteria is the revised Jones criteria. Okay, revised Jones criteria. Okay, JONES, we have seen. For infective endocarditis, what is the criteria name? The name of this criteria is called as the modified Duke's criteria. Okay, to establish the diagnosis, okay, we use modified Duke's criteria. So according to modified Duke's criteria, there should be at least two major criteria. Okay, two major criteria. At least you need to have two major criteria. Okay, or two major criteria, or one major with three minor criteria. One major along with three minor criteria should be there. What are the major criteria? What are the minor criteria? That I will discuss. There should be at least two major, or one major with three minor, or zero major with five minor criteria. At least the five minor criteria should be there in the absence of major criteria. So just tell me, what is the criteria used for the diagnosis of the infective endocarditis? It's a modified Duke's criteria. According to the modified Duke's criteria, there should be at least two major criteria, or one major with three minor, or zero major with five minor criteria should be there in order to put the diagnosis of infective endocarditis. Now, having said that, without any further late, now let's discuss about the major criteria. What are the major criteria, sir? The major criteria includes one, the laboratory thing. It's a blood culture, simple blood culture. Imagine a patient is coming to you and he is having fever, and now you are suspecting, imagine you are suspecting that this patient is having infective endocarditis. Then what you will do is you are going to take the blood, you are going to collect the blood, and you are going to send it to the lab where the blood culture is going to be done. So in this culture, if you find out the organisms, the infective agents in the blood, so there is infective endocarditis in the endocardium, the organisms are thriving. Okay, they are making the party over there. Okay, in the heart there is party going on for the microbes. So there will be dissemination of these microorganisms. All these microorganisms are going to be disseminated through the entire body in the blood. Okay, so if you just collect a blood sample and if you just culture it, definitely microorganisms are going to grow. Okay, so positive blood culture for typical organisms like Streptococcus, Staph aureus, or Hesse group of organisms. Okay, Hesse group of organisms. There are these organisms like Haemophilus. Okay, Haemophilus, Aggregatobacter, Cardiobacterium, Homines, Eikenella, and Kingella species. Okay, so these are the Hesse group of organisms: Haemophilus, Aggregatobacter, Cardiobacterium, Eichinella, Kingella. So if you are getting a blood culture positive with these organisms, how many blood cultures should come positive? At least 2 blood cultures should come positive. Okay, so at least 2 blood cultures should come positive. That's the MCQ. Okay, so you have taken the blood culture, you have taken the blood sample and you are culturing it coming positive. Not one time, again after some time you have to again take the blood, and even then the blood culture should come positive for the same organism. First time the blood culture is coming positive for the Staph aureus, and second time also the blood culture should come positive. Okay, usually we will take 3 blood samples. Okay, 3 blood samples. In the 3 blood samples, at least 2 should come positive for the same organism. Then you can say yes, one criteria is met, one major criteria is met, and the major criteria is going to be positive blood culture. Okay, but one exception over here is, so normally you need to get the 2 blood cultures that should be positive. But if you have this organism Coxiella, okay, Coxiella bruneti, so this Coxiella Q fever one, so this Coxiella, if this organism, if it is coming positive, usually it's very atypical organism, so it's usually not found in our blood. But if it is present, even one culture, you can say yes, one major criteria is met. So single blood culture for Coxiella bruneti can be considered as one major criteria. Done. Second thing, echocardiographic. Okay, first one is the laboratory thing. Okay, second thing is the echographic finding. On echocardiography, whenever you do the echocardiography, now imagine this is the heart, this is the valve. Okay, this is the mitral valve, this is the left ventricle. Okay, now what happens is, so the microorganisms are growing on the wall. So these microorganisms, what they forms is, they damage the wall. The microorganisms are going to damage the wall. Whenever the walls are getting damaged, the platelets will start to come and get accumulate over there. And these microorganisms, platelets, fibrin, all they forms is this vegetations. So vegetations are going to form on the walls. Okay, so these vegetations are full of bacteria, sir. These are the vegetations full of bacteria. So on echocardiography, what you can appreciate is intracardiac mass or intracardiac abscess, which is present on the walls. Okay, which is present on the walls. Okay, so the second finding is echocardiographic finding. On echocardiography, what you can find is these vegetations on the wall. Okay, done. And the third finding, this is the keyword, sir, to put the diagnosis of infective endocarditis. If I am the one who is appearing for the exam, this is the one thing which I will keep in your mind. Whenever you see the word new onset murmur, whenever you see this word new onset murmur, you should always think about infective endocarditis. So what is this new onset murmur? New onset murmur, dekho, now you already know. Sir, he is a patient of acute rheumatic heart disease. He is a patient of rheumatic heart disease. Now, if he is a patient of rheumatic heart disease, you know it. Sir, this patient will be having valvular lesions, valvulitis will be there, mitral regurgitation, you know it. So now, you have treated him, everything is okay, but he is at a risk of what? This patient is having a pre-existing valve lesion. Now, these patients are at a risk of developing infective endocarditis in the future. Now, the same patient is going to show up after 1 year to your clinic. Now, in this patient, now you are hearing a murmur which is not present previously. New onset murmur, sir. New onset murmur. Why? Because, see, the walls are going to be damaged. The valve leaflets are going to be damaged, so that there is regurgitation of the blood. The valve leaflets, there is going to be abscess formation in the valve leaflets. So, there will be complete destruction of the valve. The valve is going to be completely destroyed, so that there is regurgitation of the blood. So, this regurgitation of the blood is causing the murmur sound. So, new onset murmur is because of the valvular damage, leaflets damage. Okay. So, these are the 3 major criteria which you need to know for your infective endocarditis. What are the 3 major criteria? One major criteria is the laboratory finding, blood culture. Second is echocardiographic finding. And the third one is the auscultatory finding, that is the new onset murmur. Okay. Done, sir. Now, in your exams, they will ask you, so the vegetations, whatever are seen, these vegetations they go, sir, are these vegetations are going to be septic vegetations or sterile vegetations? Guys, these vegetations are going to be purely septic vegetations, sir. Like bacterial party is going on in the body. Okay, billions and billions of bacteria are circulating in the blood. So these are the platelet microthrombi which are totally filled with the bacteria. So these vegetations, they will ask you in your exam. The vegetations are made up of what? So the vegetations are made up of platelets. True. Fibrin, bacteria and some inflammatory cells. Okay, T lymphocytes, B lymphocytes, the plasma cells. Okay, so vegetations are made up of what? Platelets, fibrin, bacteria. See, bacteria. So these vegetations are septic vegetations. Okay, so these vegetations are going to cause a destruction of the wall. Destruction, wall damage is going to occur. That's causing the murmur. Okay, new onset murmur, sir. Okay, having said that, now let's discuss about the minor criteria. Okay, the minor criteria. Three major criteria done. So what are the minor criteria? First minor criteria, if the patient is having any pre-existing valvular lesion or any risk factor, you know, IV drug abusers are at risk of developing infective endocarditis, true. Acute rheumatic fever. So, predisposing heart conditions like valvulitis, mitral regurgitation, mitral stenosis, rheumatic fever, some heart disease, hypertension. So, pre-existing heart lesion or IV drug abuse. So, if the patient is having any of them, you can consider it as a minor criteria. You can consider it as a minor criteria. So, first minor criteria completed. Okay, risk factor. Second minor criteria is the patient is going to have the fever. So, it's an infection, right? The patient is having severe infections in the body. So, definitely these patients are going to have the fever. So, temperature, increased temperature or the fever. Okay. First is the risk factor. First minor criteria is the risk factors like IV drug abuse or the pre-existing heart lesion. Second risk factor is going to be the fever. Third risk factor is the immunological phenomena. Okay. So, what exactly are these immunological phenomena? So, this is very, very important. Very, very important for the exams. So, this immunological phenomena is because of the production of the antibodies. Okay. So, the antigen antibody complexes. Now, the patient is having infection. Severe infections. So, the body is going to respond by producing the antibodies. So, these antigen antibody complexes, now they start to circulate in the blood. The antigen antibody complexes are going to circulate in the blood. See, these antigen antibody complexes, they will start to deposit in different parts of the body, causing inflammation, okay, and causing the damage in the tissues. So, one such thing is the oscillatory nodes. So, in your exam, especially in the board exams like usmle, this is very important, oscillatory nodes. What exactly are oscillatory nodes? I used to remember something like oscillatory nodes start with the letter A. These are the painful lesions. Okay, these are the painful lesions. Where, sir, these are the painful lesions which are going to especially occur in the palms and soles. Okay, let me show you. Here they go. So, the patient is now having this maculopapular, see, red maculopapular lesions. Why? Why? These are nothing but immune complex depositions in the palms and soles. So, these are very much painful lesions, painful, tender, subcutaneous lesions which are present in the pulp of the finger. This is the classical word that they will use in your board exams, like pulp of the finger, in the pulp, in the finger pulps. Okay. So, because of the deposition of the immune complexes, there will be localized tissue damage with a little hemorrhage leading to maculopapular rashes kind of thing. So, that is called as the oscillatory node. Oscillatory node, sir. Next, Roth spots. See, what exactly are the Roth spots? Same immune complex depositions are going to deposit in the retina. Okay, retina, and these immune complexes will activate the complements and do a lot of mess over there. At the end of the day, retinal hemorrhages will occur, sir, because of this immunological phenomena, the immune complex deposition. Retinal hemorrhages are going to occur. So, these retinal hemorrhages are called as Roth spots. Okay, oval retinal hemorrhages. So, these Roth spots are not only specific for this infective endocarditis, they are seen in other conditions also, like leukemia, diabetes mellitus, pernicious anemias. Okay, so this one. So, what are the two immunological phenomena I have discussed? One is the oscillatory nodes. Painful. Okay, painful maculopapular lesions in the palms and soles, in the pulp of the finger. Second thing is the Roth spots. Roth spots are the oval-shaped retinal hemorrhages. They are not only seen in infective endocarditis, but they can also be seen in leukemia, diabetes mellitus, as well as pernicious anemia. And the third one is post-streptococcal glomerulonephritis. These antigen antibody complexes will start to deposit within the glomerulus, leading to post-streptococcal glomerulonephritis. You know, hematuria, hypertension, or oligouria can occur. Like these immune complex deposition in the mesangium, in the glomerulus will cause inflammation. Post-streptococcal glomerulonephritis. So, immunological phenomena is also completed. So, done. Next is the vascular phenomena. Okay, see, they will ask you again and again, I am telling you, post-streptococcal glomerulonephritis is because of immunological phenomena, not the vascular phenomena. Roth spots are because of immunological phenomena. Oscillatory nodes are because of the immunological phenomena. Then what the hell are these vascular phenomena? So, what the hell is this vascular phenomena? See, I told you, so there is this microbiological potty going on. Okay, so these vegetations, actually I am showing in big size. I should show you something like this. Okay, so there are thousands and thousands of the small vegetations are present over here. So these vegetations are very much friable. They are very much friable. So they are very weak. They are not tight. So with every heartbeat, these small vegetations may embolize. They will embolize. These septic vegetations, they are getting embolized, which means disseminating the bacteria to the entire body. The small embolus, they will got lodged into the blood vessels. They will block the blood vessels. Even they can block the they can block the blood supply to the brain. If they are large enough, they can block the blood supply to the brain. So that patient who is having infective endocarditis may develop stroke. True, possible. So now look here, this vascular phenomena, it's because of the septic emboli. Okay, it's because of what? It's because of the septic emboli, sir. So these emboli, they will go into the arteries and block the blood vessels. So arterial embolization can happen. Okay, so that can lead to infarcts, septic infarcts. Okay, septic pulmonary infarcts. Okay, and let me write here, there is a possibility because of the septic emboli, there is a possibility of stroke. Okay, next, mycotic aneurysms. Mycotic aneurysms, you know it, in yesterday's class we have discussed the mycotic aneurysms are because of the bacterial involvement to the blood vessels. Okay, can lead to mycotic aneurysms. The most common cause of the mycotic aneurysm is going to be Staph aureus. The most common blood vessel involved is the femoral artery. In yesterday's class we have discussed. So mycotic aneurysms can occur. Possible mycotic aneurysms. So mycotic aneurysms, septic pulmonary infarct, stroke, arterial embolization, all are because of the vascular phenomena. Simple vascular phenomena means these embolus, small vegetations are getting disseminated in the body. Okay, spreading the bacteria. And one more vascular phenomena. Okay, one more vascular phenomena is the Janeway lesion. So what are these Janeway lesions? See, Janeway lesions are also simple, just like ossular nodes. Okay, just like ossular nodes. These are the also red maculopapular lesions in the palms and soles, but they are non-tender. Very important MCQ. If they mention the word tender, then they are ossular nodes. But if they are mentioning non-tender maculopapular lesions which are seen in the palms and soles in a patient who is having this infective endocarditis, then they are Janeway lesions. Janeway lesions are non-tender. Ossular nodes, it's a painful condition. That's it. Okay, so fourth minor criteria is also completed. Just as a recap, what are the four minor criteria we have discussed? One is the first, previous history of IV drug abuse, or predisposing heart conditions like valvulitis, mitral regurgitation, mitral stenosis, or acute rheumatic heart disease. Second one is fever. The patient is having fever. And the third minor criteria is immunological phenomena. The fourth minor criteria is vascular phenomena. And now the fifth minor criteria is the positive blood culture. Now students are scratching their head. Some students might start scratching their head. So the positive blood culture is considered as a major criteria, right? It's considered as a major criteria. But sir, remember, there should be at least 2 blood cultures that should be coming positive. At least 2 blood cultures should be coming positive, sir. But what if one blood culture is coming positive? Only one blood culture is coming positive. So it is not meeting the criteria of the major things. It's not a major criteria. If one blood culture is coming positive, then it should be considered as a minor criteria. Okay, not meeting the major criteria. So positive blood culture, yes, but not meeting the major criteria. Means one blood culture is coming positive. So done, sir, with this. We have also completed the minor criteria. And not only this, here I want to add a few more important points because of the immunological phenomena. Okay, because of this immunological phenomena. Now also write splinter hemorrhages. Okay. Okay, splinter hemorrhages. Because of the deposition of these immune complexes in the nail beds, there will be hemorrhages, splinter hemorrhages. So splinter hemorrhages can also occur in infective endocarditis. They will show you a nail image. They will show you here. I haven't kept that, but anyway, here they are going to show you a nail image with the little hemorrhage inside the nail. That is called as splinter hemorrhages. That is also seen in the infective endocarditis, and that's also can be considered as a minor criteria. One minor criteria, sir. Okay, done. So what are the complications? Okay, let's discuss about the complications. What are the complications which are seen? Same, here the patient is having Severe infection is there. Okay. Now, in such severe infective conditions, there will be definitely splenomegaly happening. Okay. Spleen is lymphoid organ, so splenomegaly is going to happen. Now, what might be the reason? What might be the reason the patient is going to have hemiplegia? What do you think? What do you think the patient is going to have the hemiplegia? What might be the reason? Because of the stroke. Because of the stroke, the patient might develop hemiplegia. Because of the infection, the patient can develop splenomegaly. Such a big spleen is going to be seen, sir. Such a big spleen, the splenic tip is going to be palpable. Okay. See, though I am teaching pathology, I am just trying to integrate as much as possible. Why? Because 100% a question is going to come from this area. Okay. And there can be clubbing. Okay. Because of the septic pulmonary infarcts, the lungs are going to be involved. So there can be clubbing. Okay. The blood vessels are going to be blocked. You know it, right? And new onset murmur, I have explained you, the new onset murmur due to perforation, the valves are going to be damaged. So because of the development of the perforation within the valves, there can be regurgitation. That can lead to new onset murmur. Okay. So out of these three major criteria, if you have at least two minor criteria, yes, done. So the patient is having now infective endocarditis. Or at least one major criteria along with three minor criteria. What are the? It can be anything. One out of the three: fever, IV drug abuse, or vascular phenomena, immunological phenomena, positive blood culture, which is not meeting the criteria which is not meeting the major criteria. Done. Okay. So these are the minor criteria done. Now, what is the treatment? So treatment. Usually, first, when a patient is coming with infective endocarditis, first we will start immediately, empirically. We don't know what is the organism. We don't know exactly what is the organism that's causing the infective endocarditis. Yeah, major criteria and minor criteria, they are met. So immediately you have diagnosed that, okay, this patient is having infective endocarditis. So immediately start, okay, penicillin G. Immediately start penicillin G. Okay. So immediately start the penicillin G. Okay, penicillin G or ampicillin. Okay, penicillin G, ampicillin along with gentamicin. Okay, plus methicillin or vancomycin. So this is the combo, sir. So penicillin G or ampicillin, one drug, gentamicin, methicillin, gentamicin, methicillin, gentamicin. Sorry, let me put it this way. Gentamicin plus methicillin. Okay, gentamicin with methicillin or vancomycin. So this is the empirical treatment done. But once after attaining the cultures, for the then you can start the anti microbial drugs for the appropriate agent. So appropriate treatment can be done after attaining the culture. Okay, if the organism is Hayseck group of organisms. Okay, if it's coming as a Hayseck group of organisms, then the drug that is preferred is the ceftriaxone. That's the third generation cephalosporin. Okay, ceftriaxone. In one of the exam, they have asked if there is a valve abscess. Okay, there is a valvular abscess. Now, if there is a valvular abscess, then you have to use the rifampicin. Why? Because other drugs cannot penetrate into the abscess. Okay, the antibiotic drugs, other antibiotic drugs, they cannot penetrate into the abscess. So the rifampicin have a capacity to penetrate into the abscess and can kill the microorganisms. There is a valve abscess, the ring abscess, then rifampicin. As a group of organisms, ceftriaxone as an empirical treatment, you can use penicillin G or ampicillin along with gentamicin and methicillin. Okay, done. So with this, completed. Infective endocarditis topic completed, sir. Now, let's talk about the vegetations. Okay, very important for your exams. The comparison of different types of vegetations in endocarditis. See, we have discussed about the vegetations in acute rheumatic fever also. In acute rheumatic fever or rheumatic heart disease. Okay, in rheumatic heart disease also we have seen the vegetations are there. But those vegetations are sterile vegetations. Those vegetations are present along the line of closure. They are not fribble vegetations. They do not undergo embolization that easily. But right now what we have discussed? We have discussed about the vegetations in which condition? Infective endocarditis. They are absolutely different. So now, see, in rheumatic heart disease, the vegetations are different. Infective endocarditis, NBD, non-bacterial thrombotic endocarditis, and LSE, Liebman-Sachs endocarditis. There are these four conditions in which you can have the vegetations in the heart. We can have the vegetations in the heart. But what are the differences? What are the differences in these vegetations? We'll discuss one by one. Okay, देखो, sir, in rheumatic fever, In yesterday's class we have discussed where the vegetations are present. The vegetations are present along the line of closure. Vegetations are seen along the line of closure. These vegetations are sterile vegetations. They are small and firm, which means they do not undergo embolization. They are firm vegetations, like they are tough things. Okay, they are small, firm, wart-like, and they are non-destructive. They do not cause any damage to the wall. They do not cause any damage to the walls. Non-destructive. Okay. Now, what we have discussed just now, we have discussed about the infective endocarditis. Okay. So, infective endocarditis, go here. Same. This is rheumatic heart disease. In rheumatic heart disease, see how beautifully the vegetations are. Of course, the vegetations are not beautiful at any cost, but see, they are arranged along the line of closure. Okay, they are present along the line of closure, sir. Done. In infective endocarditis, see, the walls are getting damaged because of this vegetation. They are very big vegetations. They are erosive in nature. They will cause damage to the walls. Okay. Now, let's see. They are large, irregular vegetations. They are non-sterile or septic. They are septic in nature. Where they are present? They are present along the line of closure? No, they are present above the wall as well as below the wall. Okay, they are present on both the sides. But most commonly, MCQ, most commonly they are present on the upper surface of the wall. Okay, upper side of the walls. Okay, so they are explained you, they are destructive. Okay, they are destructive. They are most prone for embolization. Okay, they are most prone for embolization. So whenever they undergoes embolization, we have discussed vascular phenomena, embolization. Okay, septic pulmonary infarcts, there can be stroke. Okay, these vegetations are going to the spleen causing splenomegaly. Okay, hemiplegia can occur. We have discussed. Now, after this, two types of vegetations. Now, let's discuss about NBT, non-bacterial thrombotic endocarditis. See, there is no bacteria, but endocarditis is happening. Non-bacterial thrombotic endocarditis, thrombosis is happening. Okay, thrombosis, all these are the platelet microthrombi going to form on the walls. Platelet microthrombi, they are forming the vegetations on the walls because of non-bacterial in origin. They are not rheumatic vegetations. They are not infective endocarditis vegetations. Then these are seen in which conditions? Dekho, there are certain hypercoagulable states. This is important. There are certain conditions in your body where your blood is becoming hypercoagulable. In which conditions? Certain types of cancers like AML, acute myelogenous leukemia. Okay, acute myelogenous leukemia, especially M3 type. Okay, in hematology we will study. Sir, in this M3, acute, in this AML, what happens is the blood will become hypercoagulable. Okay, R rods are going to be seen. We will discuss later. Okay, the blood is going to be hypercoagulable. So, in those conditions, wherever there are hyperestrogenic states, estrogen, it increases the clotting factors. Estrogen normally makes the blood hypercoagulable. So, hyperestrogenic states, if a female is having hyperestrogenic state because of some ovarian cancer, like granulosa cell cancer, there is a chance that she might develop non-bacterial thrombotic endocarditis, hyperestrogenic states. Okay. So, in this hyperestrogenic states, in certain types of cancer, the blood is going to be hypercoagulable. The clots, now these clots are going to occur on the walls. Okay. So, these are small. They are also friable. See, they are also friable. Friable means they will easily detach. They are small. They will be easily detaching. And what they will do? They will do embolization. They will go for the embolization. Okay. So, they are more prone for embolization. Yes. Okay. True. And these are septic? No, these are not septic, sir. These are sterile. Not because of the bacteria, because of some cancerous condition. Right. So, they are sterile. Okay. Now, these vegetations are also going to be seen along the line of closure. Okay. So, now tell me, in which conditions the vegetations are going to be seen along the line of closure? It is both rheumatic heart disease as well as non-bacterial thrombotic endocarditis, and they are non-destructive. Who is destructive? Infective endocarditis vegetations are going to be destructive. Non-bacterial thrombotic endocarditis, they are non-destructive, and rheumatic heart disease are also non-destructive. Who is more prone for embolization? Infective endocarditis vegetations are going to be more prone for embolization, and even this non-bacterial thrombotic endocarditis, they are also prone for embolization, sir. Both are small and friable. Non-bacterial is small and friable. Infective endocarditis is large and friable. Okay, large and friable. And last one, the Liebman-Sachs endocarditis. Okay, Liebman-Sachs endocarditis, I used to remember like L. Okay, L, Liebman-Sachs endocarditis. See, L-S-E, right? L-S-E. I used to just rearrange the name LSE as SLE. The systemic lupus erythematosus Okay, autoimmune condition. So, in this autoimmune disorder, SLE, there will be Liebman-Sachs endocarditis. In this autoimmune condition, multiple systems are going to be affected. In Liebman-Sachs endocarditis, multiple systems are going to be affected. Also, endocardium will be affected. Okay, also endocardium will be affected. So, endocarditis is going to be there. Again, vegetations are going to occur. These vegetations, again, they are not bacterial in origin. They are again going to be sterile vegetations. So, sterile. See, dekho. Here also sterile. Here also sterile. Here also sterile. Everywhere the vegetations are sterile, except in infective endocarditis, they are septic vegetations or non-sterile vegetations. Okay. Now, where they are present? See, I used to remember the word L. In Liebman-Sachs endocarditis, L, sir. L stands for they are present especially on the lower side of the wall. Okay, especially on the lower side of the wall. Infective endocarditis, upper side. Okay, upper side. How I used to remember is, sir, infective endocarditis is much more a serious condition. Infection to the heart, sir. The patient is going to go up. Okay, so go up, sir. He's taken the pass to go up. Okay, so the vegetations are going to be seen most commonly on the upper side. In Liebman-Sachs endocarditis, the letter starting with the L, so lower surface of the wall. The other two, rheumatic heart disease and non-bacterial thrombotic endocarditis, the vegetations are going to be seen along the line of closure, along the line of the closure. Okay, next, sir, these vegetations are going to be medium sized. Okay, medium sized vegetations. Okay, so present on both the surface of the wall. Okay, so these points are very much enough. These points are very much enough for you for your exams. Okay, so there are 4 different conditions where you can see the vegetations. One is rheumatic fever, non-bacterial thrombotic endocarditis, Liebman-Sachs endocarditis, and infective endocarditis. How to differentiate them? Done. Okay, done. So with this, vegetation topic is also completed. Now after this topic, now let's begin with cardiomyopathies. Okay. So how many types of cardiomyopathies are there? Okay. How many types of cardiomyopathies? So in the name itself is there. First, dekho, cardio means what? Cardio means heart. Myo means muscle. Patho means pathology. Some heart, some problem with the muscle in the heart. Okay, some problem to the heart muscles. Cardiomyopathies. So these cardiomyopathies are of 3 types. What are they? One is hypertrophic cardiomyopathy. Let's say hypertrophic cardiomyopathy. Okay, hypertrophic cardiomyopathy. Next, dilated cardiomyopathy, DCM. Next, restrictive cardiomyopathy, RCM. Okay, let's put it this way, simple HCM, hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, dilated cardiomyopathy, and restrictive cardiomyopathy. There are 3 types of cardiomyopathies. What you need to know for your exam? Let's keep it as simple as possible. Okay, let's keep it as simple as possible. Sir, hypertrophic cardiomyopathy, what exactly is happening in the names? Dekho, hypertrophy of the muscle, hypertrophy of the myocardium. The myocardium is becoming bigger. Which myocardium? Where? In the atrium? Atrial myocardium, even in the atrium muscle cells are there, right? So, is atrium getting hypertrophic? No. Where? Hypertrophy, dekho. So, you can very clearly see here, this is a normal heart. Okay, here is a normal heart. Now, appreciate the interventricular septum. Okay, it is thin, it's thin and nice. Okay, but in hypertrophic cardiomyopathy, let me put it here itself. This hypertrophic cardiomyopathy is also called as hypertrophic obstructive cardiomyopathy, HOCM. Okay, both are true. So both are the same names, hypertrophic cardiomyopathy or hypertrophic obstructive cardiomyopathy. Both can be used interchangeably. Okay, now here what happened is there is asymmetrical septal hypertrophy. Okay, the septum, the interventricular septum, because of certain gene mutations. Okay, because of certain gene mutations, the interventricular septum is getting hypertrophied. Okay, so extra muscle, sir. Extra muscle. There is hypertrophy. More muscle means it needs more oxygen. So the oxygen demand by the heart increases. One more problem they go. Sir, because of this extra muscle, see how much thicker muscle it is. Such a thick muscle, sir. Such a thick muscle. Asymmetrical septal hypertrophy. Because of this, look at the heart chambers. What is happening to the left ventricular chamber? The left ventricular chamber is getting reduced. Okay. So now the left ventricular chamber is very much narrowed down. So do you think that diastolic filling is going to happen properly? The filling, sir, the filling of the left ventricle is going to happen normally, normal. End-diastolic volume is going to be normal? No, definitely not. Why? Because the left ventricular compliance decreases, sir. Okay, very less space is there. So now tell me, what is the problem? The problem is going to be filling defect. Diastolic problem, the main problem is going to be diastolic problem. Okay, so because of the less size in the left ventricular cavity, the filling is not happening properly. When filling is less, automatically the output is going to be less. The stroke volume is going to be less. The cardiac output is going to be less. So whenever this patient will do certain exertion or certain activity, what happens? He is not getting enough. He's already having less cardiac output, less stroke volume, less BP. Whenever he tries to do certain extra activity like exercise, his heart cannot meet the demand by the body. So there will be syncopal attacks. Suddenly he is going to fall unconscious. Okay, I will discuss one by one. That thing I will discuss one by one. But anyway, so what is the problem here? Mainly the problem here it is asymmetrical septal hypertrophy. Okay, so let's write one by one important points. Look, dekho here. So here the left ventricular cavity, how it is looking like? This is a question asked. Because of the septal hypertrophy, the left ventricular cavity is looking like a banana, sir. So there is banana shaped cavity. So there is banana shaped cavity of the left ventricle, banana shaped cavity, sir. Now, what else I can ask you? See, normally in a normal healthy myocardium, this is how the histology is going to look. Okay, normal healthy myocardium, sir. See how beautifully the cardiac myocytes are arranged. Okay, see how beautifully the cardiac myocytes. All these are the cardiac myocytes with intercalated discs, striations. Everything is perfectly all right, right? See how beautiful they are. Okay, properly arranged cardiac myocytes. But in this hypertrophic obstructive cardiomyopathy, HOCM, what happens is, how is the myocardium? Image-based question. Now here, these myocardial cells, these myocytes are branched totally. There is something called as a disarray. Okay, disorganization. Okay, they go here, see, they are not properly organized. So there is something called as myocardial disarray. Okay, right? Myocyte. On histology, image-based question, very important. Myocyte. There is myocyte disarray seen in hypertrophic obstructive cardiomyopathy. So let's write one by one important point. HCM or HOCM, hypertrophic obstructive cardiomyopathy. See, out of the three cardiomyopathies, which is the most common? Which is the most common cardiomyopathy? It's the HCM, sir. Most common cardiomyopathy. Okay, HCM is the most common cardiomyopathy. Pathology books, some pathology books, Robbins mentions dilated cardiomyopathy is the most common cardiomyopathy. But medicine books, okay, we as a doctors, we believe mainly in the medicine books, the Harrison books, it's a hypertrophic cardiomyopathy is the most common cardiomyopathy. Okay, Robbins mentions dilated cardiomyopathy is most common. Harrison mentions it's a hypertrophic obstructive cardiomyopathy is the most common, sir. Okay, so it's the autosomal dominant disorder. Okay, it's the autosomal dominant disorder. Here, having said that autosomal dominant disorder, one point I want you to know is, sir, usually one of the family member, in the question they will give you, one of the sibling or the father have died with some heart disease, sir. Okay, usually the sibling, okay, history, there will be history of sibling or parent died with sudden cardiac death. Okay, there is a sudden cardiac death. Okay, so simple, very simple. The person, the sibling is simply playing in the field. Okay, 10-year-old boy or 15-year-old boy, he's simply playing. He's not even athlete, sir. He's not. They can never be athletes. These patients can never be athletes. Okay, it's not the athlete. It's not the athletic heart. That's a total different thing. An athlete who is playing in the soccer field have died. That's an athletic heart. That's a total different condition. See, these patients, the hypertrophic obstructive cardiomyopathy patients, they will never become an athlete, sir. Okay, usually they are playing in the household, in the normal streets or in the normal school games. Suddenly they fell. while playing the game, they fail, sir, because of the sudden cardiac death. Because of this hypertrophic obstructive cardiomyopathy, actually these patients are at a risk of developing arrhythmias. They will develop arrhythmias. Okay, so because of this arrhythmias, they will fail dead. I will discuss about that also. Okay, so first, this disease is autosomal dominant in inheritance pattern. Usually, they are associated. Okay, associated with one of the sibling. I shouldn't say associated. One of the sibling in the family have died with a sudden cardiac death. So, what is the problem? Asymmetrical septal hypertrophy. Okay, there is asymmetrical septal hypertrophy, sir. Now you can ask me why the problem, why asymmetrical septal hypertrophy, why it is happening, sir? Because of some certain gene mutations. What are the gene mutations? The gene mutations is going to be MYH7 gene mutation. Okay, MYH7 gene mutation. This MYH7 gene which is present on the chromosome number 14. Okay. So this is because of the gene mutation, there is asymmetrical septal hypertrophy that's going to be happen, sir. Now you can ask me, sir, if there is asymmetrical septal hypertrophy, what is the problem? Asymmetrical septal hypertrophy, there is an extra muscle present. This extra muscle is demanding more and more oxygen. It demands more and more blood supply. So because of this extra muscle, there will be subendocardial ischemia. Okay, subendocardial ischemia followed by myocardial infarction. There is a possibility. Okay, so these patients can develop subendocardial ischemia, sir. Now, in this hypertrophic obstructive cardiomyopathy, is it systolic problem or diastolic problem? Sir, mainly it is, of course, both systolic and diastolic, but mainly it is diastolic dysfunction. Diastolic dysfunction. Okay, diastolic dysfunction. Why diastolic dysfunction? Because the left ventricular cavity is going to be banana shaped, it is not going to fill properly. So what happened to the end diastolic volume? End diastolic volume decreases. So what happened to the stroke volume? Stroke volume also decreases, end diastolic volume decreases, stroke volume decreases. When stroke volume is decreasing, okay, especially when these patients are trying to do certain exertion or exercise, there will be syncopal attacks. Okay, there will be syncopal attacks with exertion. Okay, with exercise, sir. Okay. Okay. Next, what else are the problems which are seen in these patients? What else are the problems, sir? Now, देखो here. See, in this hypertrophic obstructive cardiomyopathy, what exactly happens is, I am saying the word right, HOCM, hypertrophic obstructive cardiomyopathy. You know the word, why I am using the word hypertrophic? Because of the asymmetrical septal hypertrophy. Then why the hell I am using this word obstructive? Why this word obstructive, sir? This word obstructive, it is because of, देखो, look here, because of this asymmetrical septal hypertrophy. Now, what happened to the left ventricular outflow tract? Left ventricular outflow tract, there is an obstruction. The left ventricular outflow is getting obstructed, sir, because of this septal hypertrophy that is happening at that, at this level. Okay, at this level, there is obstruction. One thing. Okay, first let's write that. Okay, there is subvalvular aortic stenosis. There is subvalvular aortic stenosis. See, there is no problem with the aortic valve. Aortic valve is okay. There is no problem with that. But below the valve, there is an obstruction. Okay, below the valve, here see, there is an obstruction. So, subvalvular aortic stenosis is seen in hypertrophic obstructive cardiomyopathy. True. Next, one more problem is, sir, in these patients, so this is the mitral valve, right? This is the mitral valve. So, this leaflet, okay, the mitral valve leaflet, okay, so I used to remember something like this, okay. So, there is a left ventricular outflow tract obstruction. The left ventricular outflow is getting obstructed, narrowed down. So, blood is going to go as a jet, sir, with high velocity. See, whenever the outflow is getting obstructed, narrowed, what happened to the jet of blood? Is going to go very rapidly, very rapidly. See, of course, less blood is going, no doubt, less blood is going, but with high velocity the blood is going because the outflow tract is getting obstructed. when the blood is going with such a high velocity, what happens is, so that high velocity blood will actually draw this this mitral valve leaflet. This mitral valve leaflet is going to be displaced, sir. So this is something called as SAM, systolic systolic anterior displacement of mitral valve. Systolic anterior displacement of the mitral valve, sir. So what exactly is the systolic anterior displacement of the mitral valve? I have explained you. Say simple. When the jet of blood is ejecting into the aorta with such a high velocity, this high velocity blood will actually drag the mitral valve. It will actually drag the mitral valve towards the septum. So this mitral valve, dekho, what happens is, it was supposed to be closed, sir. It was supposed to be closed during systole, but now this mitral valve is going to be moved. So now what happens? The obstruction is going to be further aggravated. Now there is more obstruction. Now this mitral valve leaflet is going to be displaced, which is causing more obstruction for the blood flow. So both these two, the subvalvular aortic stenosis and left ventricular anterior displacement of the mitral valve, okay, which is called as a SAM. Remember, SAM, systolic anterior displacement of the mitral valve, SAM. Both of them together account for left ventricular outflow tract obstruction. Okay, left ventricular outflow tract obstruction is going to be seen because of these two mechanisms: subvalvular aortic stenosis, systolic anterior displacement of the mitral valve. So again, systolic problem. These both are systolic problem. Here we have discussed about the diastolic problem. Okay, the left ventricular filling is going to not occur properly. Okay, the left ventricle is not being properly filled. This is the one problem, and the other problem is going to be systolic problem because of the subvalvular aortic stenosis as well as the systolic displacement of the mitral valve. Okay, systolic anterior displacement of the mitral valve. So it's both systolic problem as well as diastolic problem. Okay, so here they will use this one word. I want you to know this is something called as dynamic left ventricular outflow tract obstruction. Why dynamic? Why dynamic is because simple. Okay, it's not continuous. It's not a continuous obstruction. This systolic anterior displacement is happening. The systolic anterior displacement of the mitral valve. During systole, the mitral valve is going to be displaced, causing more obstruction. So it's a dynamic obstruction. Okay, for the blood flow. Done. After this, what else you should know? Sir, in this HOCM, there is an obstruction. Okay, here the left ventricular outflow tract, see, it's so much obstructed, sir. It's so much narrowed down. Subvalvular aortic stenosis is there. Now, when the blood is ejecting into the aortas with such a rapid force, with such a rapid velocity, definitely it's going to cause a murmur. Am I right or not? Definitely it's going to cause a murmur. What is that murmur heard in this condition is crescendo, decrescendo, murmur. So there will be diamond shaped murmur or crescendo decrescendo murmur, sir. Okay, so in the murmurs topic, you will study these things in much more detailed way. So these HOCM patients are going to have what kind of murmur? Very, very important. So aortic stenosis or subvalvular aortic stenosis is going to cause crescendo decrescendo murmur. There is one more name. It's also called as systolic ejection murmur. Systolic during systole, the murmur is there. So systolic ejection murmur. Okay, systolic ejection murmur, sir. So done. So how you will get a case usually? Usually how you will get a case, sir? You will get a case something like a young boy. Okay, young boy. Okay, he is going through the sports activity. Okay, sports activity. Sir, he is not an athlete. He can never become the athlete. Why? Because by birth itself he is having the problem. So whenever he try to do some exertion, simple walking on the stairs, he will make his he is going to develop the dyspnea. He is going to have the syncopal attacks. He will never become the athlete. He is a general regular boy. Now whenever he try to do certain sports activity or more work, more work. Now this boy fell dead, sir. Sudden cardiac death. A question will come something like this: a young boy who indulged himself in a the school sports activity. Now he suddenly fall dead because of the sudden cardiac death. What might be the reason? See, such a hypertrophic myocardium is more prone to develop arrhythmias. Which arrhythmias? Mainly there will be ventricular fibrillation. Ventricular fibrillation. So ventricular fibrillations are going to develop. So these ventricular fibrillations, okay, ventricular is like fibrillating, there will be crashing of the BP that can actually kill the patient. Okay, so sports activity, young boy, sports activity, following that there is sudden cardiac death because of arrhythmias. This hypertrophic myocardium is highly arrhythmogenic. They will develop the ventricular fibrillation, and that can actually kill the patient within just minutes. Okay, done. So what is the treatment? What we can do with these patients? What is the treatment? Treatment also very important. So whenever you know that this fellow is having hypertrophic obstructive cardiomyopathy, okay, you have done the examination. Like a boy came to you, he's saying that, like, a boy came to your clinic, his father brought the boy to the clinic, and his father is saying, sir, my boy, whenever this boy is playing in some field, okay, with small activity, he is like, becoming breathlessness, he is having syncopal attacks, he cannot do, like, more work, okay, he cannot do more work. Okay, so now you are thinking that, okay, there may be chance of this hypertrophic obstructive cardiomyopathy. Now you have done the examination, okay, on echo it's very clear that there is systolic anterior displacement is there, hypertrophic, the left ventricular septal hypertrophy is there. Now you know that this boy in the future he can develop this ventricular fibrillation and he can die. So what you have to do is, so the treatment is implantable cardioverter defibrillator, so ICD device. So implantable cardioverter defibrillator, it's a device. So whenever this patient, he develops an arrhythmia, ventricular fibrillation or any other kind of arrhythmia, it will immediately detect and it sends a DC shock, and immediately the arrhythmia is going to be terminated. So this implantable cardioverter defibrillator, this is not a pacemaker, sir. This implantable cardioverter defibrillators, they will immediately detect the arrhythmia and terminate the arrhythmia, okay, within seconds. So the treatment that's done for this patients is implantable cardioverter defibrillator. Apart from that, what else you can do is the surgical options, like that extra septal hypertrophy is there, right? That extra septum you can remove, that's a myomectomy. Okay, myomectomy can be performed, or you can perform something called as alcohol based, by injecting these chemicals, okay, alcohol based septal ablation. Okay, alcohol based septal ablation. Okay, by injecting certain chemicals, you can actually kill that part of the myocardium, that unnecessary myocardium, you can just take it down. So myomectomy can be done, or alcohol based septal ablation. But the best treatment is going to be implantable cardioverter defibrillators. They will detect the arrhythmias and send a DC shock and immediately terminate the arrhythmias. Done. Now one thing I want you to know is, see, don't confuse. So this patient is having hypertrophic obstructive cardiomyopathy. Now imagine, देखो guys, some students will confuse. Look, imagine this is the heart. Okay, now this is the aorta. This is the left ventricle. Here is the aortic valve, sir. Here is the aortic valve. Now if the aortic valve is stenosed, okay, aortic stenosis. Now there is aortic stenosis. Now even in this condition, aortic stenosis, the left ventricle, it will become hypertrophied. Left ventricular hypertrophy will occur. See, this is not hypertrophic cardiomyopathy. Okay, hypertrophic cardiomyopathy is seen in absence of all these conditions, in absence of all these valvular lesions. There is no valvular lesion, there is no hypertension, there are no such problems. So left ventricular hypertrophy, which is seen in the case of aortic stenosis, don't tell that is hypertrophic cardiomyopathy. That's a totally different thing. Okay, so hypertrophic cardiomyopathy, it is because of the mutation of a gene which is called as MYH7 gene on chromosome number 17, which is causing asymmetrical septal hypertrophy. Okay, keep that one point in mind. Now after this, look at this image and tell me what exactly is the problem. So here I am showing you the heart. What exactly is the problem? You can very clearly see the left ventricle is dilated. The left ventricle is totally dilated. Okay, Now such a dilated heart, the big heart, now it cannot contract properly. Whenever there is too much dilation is very bad. Why? Because now the heart can't contract properly. Okay, so now the topic which I am going to discuss is dilated cardiomyopathy. Okay, see, the heart chambers are dilated, not just the left ventricle, all the heart chambers will be dilated, dilated cardiomyopathy. Now the questions that will come in your exam is, right, dilated cardiomyopathy, all four chambers are going to be dilated. Okay, dilated. Now they will ask you why. Etiology. Sir, I have explained you. What is the etiology of hypertrophic cardiomyopathy? Hypertrophic cardiomyopathy is because of certain gene mutations. Okay, MYH7 gene mutation on chromosome number 14. That's one of the cause. Now, why dilated cardiomyopathy? Dilated cardiomyopathy is associated with alcoholism. Okay, alcoholism, sir. One. Next, this is the question asked. Alcoholics will develop dilated cardiomyopathy. Or because viral in origin, viral myocarditis. So viral myocarditis. What exactly is this viral myocarditis? If you get infection with certain viruses, okay, viral myocarditis, heart infection with the viruses, that can lead to dilated cardiomyopathy. Which viruses are most important? It's the parvovirus B19. The parvovirus B19. Other viruses are HHV6, human herpes virus 6, and Coxsackie B virus. Coxsackie B virus. Okay, Coxsackie B virus. So very important. So viral myocarditis, the most common cause of viral myocarditis is parvovirus B19, parvovirus B19, or HHV6 or Coxsackie B virus can lead to dilated cardiomyopathy, alcoholism. Next, apart from that, hemochromatosis, sarcoidosis. See, this hemochromatosis and sarcoidosis, both these conditions, hemochromatosis and sarcoidosis, both these conditions, they can cause both hypertrophic cardiomyopathy as well as, they can cause both dilated cardiomyopathy and restrictive cardiomyopathy. They can cause both. But dilated cardiomyopathy, DCM, dilated cardiomyopathy is most common than restrictive cardiomyopathy. When compared to the restrictive cardiomyopathy, which we will discuss later, dilated cardiomyopathy is most common, sir. Okay. In which other conditions you can have this dilated cardiomyopathy? Is going to be Duchenne's muscular dystrophy. The dystrophin protein, absence of the dystrophin protein, okay, can lead to dilated cardiomyopathy. And using of certain drugs like adriamycin or doxorubicin, or IV drug abusers like cocaine. Okay, cocaine abuse. So these conditions can lead to dilated cardiomyopathy. So alcoholism, viral myocarditis, hemochromatosis, sarcoidosis, Duchenne's muscular dystrophy, and using of certain drugs like cocaine, adriamycin, or doxorubicin. Okay, these conditions may cause a dilation of the heart chambers. Okay, now what are the important points which I want you to know here is, so देखो, what are the complications? The complications are going to be the heart chambers are getting dilated. Imagine, now this is the left ventricle that is getting dilated. If the left ventricular cavity, if it is getting dilated, see, now this valve leaflets, the mitral valve leaflets are also going to move apart from each other. The valve leaflets are moving apart from each other, so they're not coapt properly. Okay, they're not closed properly. Okay, so the coaptation of the valves is not going to happen properly. So what will happen? Regurgitation, sir. So regurgitation. So in dilated cardiomyopathy, the problem is going to be regurgitation, especially mitral regurgitation. Okay, mitral regurgitation on left side. On right side, you can have tricuspid regurgitation possible, and even this dilated myocardium. This dilated myocardium is more arrhythmogenic, arrhythmias. Okay, they will develop the arrhythmias. Okay, so mitral regurgitation, tricuspid regurgitation, and arrhythmias are going to be seen. So what is the treatment? treatment in this condition is going to be transplant, sir. Transplant. Okay, so transplantation. You need to go for the heart transplantation. That's the best option available. Important point about this dilated cardiomyopathy is the heart is getting dilated, sir. Heart is getting dilated. Such a dilated heart cannot contract properly. That's the problem. Cannot contract properly. So what happened to the stroke volume decreases, cardiac output decreases, BP decreases. Okay. So the patient is going to have the syncopal attacks again. Okay. So it's a systolic failure. It's a systolic dysfunction. You don't forget, hypertrophic obstructive cardiomyopathy, mainly it's a diastolic failure. Of course, yes, systolic dysfunction is seen. But in dilated cardiomyopathy, the main problem is systolic dysfunction. Okay, the heart cannot contract properly, dilated myocardium, right? Dilated heart. Now, after this, I want you to know a special variant, okay, special type of dilated cardiomyopathy. Variant of dilated cardiomyopathy, which is called as Tokosubo cardiomyopathy. Sir, what is this Tokosubo cardiomyopathy? So this Tokosubo cardiomyopathy is also called as broken heart syndrome. So first, why it is called as a Tokosubo? What exactly is this Tokosubo, sir? Tokosubo means, dekho, sir, this Japanese way of catching the octopus. So there is this instrument which is called as a Tokosubo. Okay, so it's used to capture the octopus. It's used to catch the octopus, sir. Okay, so see, octopus is getting caught. It's octopus trap. Tokosubo is Japanese term, or you can say that instrument. Okay, it's a Japanese way of catching the octopus, sir. Okay, so why exactly we are using this word Tokosubo? Because the heart, the left ventricular cavity is going to dilate in such a way, it's going to be dilated now in such a way, it resembles like a Tokosubo. It resembles like this jar. Okay, see, this is the normal heart, okay, normal ventricle. But dekho here, in Tokosubo cardiomyopathy, see, it's like Japanese octopus. Like, the jar which catches the Japanese jar which catches the octopus. See, now the left ventricle is dilating in such a way, now it is looking like a Tokosubo. Okay, so that's why. Now let's discuss one by one important points regarding the Tokosubo cardiomyopathy. It's also called as what? It's also called as a broken heart syndrome. Why it is called as a broken heart syndrome? See, whenever you hear about something which gives you immense stress, immense psychological stress. For example, you heard there is this one father heard that his daughter died in a road traffic accident, or his son died in a road traffic accident. The mother heard that his son died in a road traffic accident. This couple, the partner heard her lover died in a road traffic accident, something like this. Now, like they are going to have immense psychological stress. We usually see in the TV channels that after hearing that her daughter died or her son died, the mother just fell dead. Why? Why? Because of this broken heart syndrome, extreme psychological stress will produce catecholamines. Okay, so now these catecholamines, they are going to act on the heart. Now they are going to act on the left ventricle. Now under the influence of these catecholamines, now heart cavity. Okay, now dekho, so this is now this is how a normal heart looks like. But in this condition, what happens is the left ventricular cavity is going to dilate like a Tokosubo. Okay, like this, a Tokosubo. So Tokosubo, also called as a broken heart syndrome, seen in extreme psychological stresses. I have given you the example. Now there is increased levels of catecholamines. Increased levels of catecholamines can cause this dilatation of the left ventricle. Okay, here see, broken heart syndrome. I have just taken it from the internet. Tokosubo cardiomyopathy, broken heart syndrome. It's a weakening of the left ventricular muscle leading to the dilation. Okay, leading to the dilation. See, this is the actual the real jar, sir. Okay, that Tokosubo. Now after this Tokosubo cardiomyopathy, now let's discuss about the last cardiomyopathy, that is restrictive cardiomyopathy. What they will ask in your exam is Tokosubo cardiomyopathy is a type of dilated cardiomyopathy. So restrictive cardiomyopathy, what's the problem? See, there is a restriction. Restriction for what? See, the problem here in this condition is the heart, normal heart is there, right? Now, in the heart wall, unnecessary materials are going to get deposited. I used to think like this. The cement is getting deposited in the heart wall. The cement which is used to build the houses. Now this concrete, cement. Now it is getting deposited in the heart wall. Now how the heart walls are going to become like? They are going to become stiff. Are they going to be compliant now? They are not going to be compliant. Now they are stiff. So there is no proper relaxation of the heart. Okay, now there is no proper relaxation of the heart. When the heart is not properly getting relaxed, when it's not properly getting relaxed, it's again diastolic failure. The filling is not going to happen properly. Okay, the heart is not properly receiving the blood, so again diastolic failure. So important points: decrease compliance in myocardium. Okay, there is decreased compliance of the myocardium. What's the problem? Explained you. Restricts. Okay, restrictive cardiomyopathy. What it is restricting? Restricts filling. Okay, restricts the filling during diastole. Okay, so diastolic dysfunction, sir. Okay, now in this restrictive cardiomyopathy, one important point which I want you to know for your exams is all chambers in heart are of normal size. Left ventricle, left atria, okay, they're all of normal size, sir. All are of normal size. Now the questions that can come in your exam is, what are the etiologies? Okay, what are the etiology? Why restrictive cardiomyopathy? What is that cement-like material getting deposited in the heart? What is that cement-like material? Etiology is because of amyloidosis. Okay, so this amyloid protein or this amyloid material, it's getting deposited in the myocardium, leading to restrictive cardiomyopathy. Amyloidosis, the most common cause. You already know sarcoidosis. Okay, granuloma formations inside the heart, sarcoidosis, hemochromatosis. Okay, hemochromatosis. Next, endocardial. Okay, endocardial fibroelastosis. And Loeffler syndrome. See, in all these conditions, okay, just look: amyloidosis, amyloid protein deposition; sarcoidosis, granuloma formations inside the myocardium; hemochromatosis, iron deposition within the myocardium; endocardial fibroelastosis, in the name itself is there, fibrosis. Okay, fibrosis of the heart; and Loeffler syndrome. Even in this condition, again there will be fibrosis. So in all this condition, there is abnormal deposition of certain material like amyloid or some iron or some fibrous material getting deposited inside the heart. So the heart is getting stiffened. It's not relaxing properly. It is not accepting the blood. So diastolic dysfunction mainly. Okay, so done with this. Restrictive cardiomyopathy is also completed. Okay, completed. So now in this class we have discussed about the infective endocarditis, different types of vegetations. We have discussed about hypertrophic obstructive cardiomyopathy, dilated cardiomyopathy, and restrictive cardiomyopathy. Okay, so if you know this much, that will be enough for your exams. Okay, for your FMG exams, that will be more than enough. Okay, so we'll end the topic till here for today, and in tomorrow's class we will discuss about the heart failure topics. Okay, mainly we will be discussing about the heart failure topics tomorrow. Hope the video is helpful. Thank you. See you tomorrow. Good night.